Good morning, everyone. Today my topic is on glaucoma in Aniridia. It's not moving. Yeah, as you all know, Aniridia is a less common familial bilateral disorder which is of autosomal dominant inheritance. Glaucoma in Aniridia can be of either an open angle or a closed angle, wherein the irregular strands arising from the iris trauma, it attaches to the angle wall. When it becomes thicker and it moves forward, it causes obscuration of trabecular meshwork, scleral spur, and the ciliary body, and then ultimately the iris stem gets tilted and the angle gradually gets closed. The purpose of our study was to understand the incidence and the management techniques of glaucoma in Aniridian children. This was a retrospective analysis of 22 eyes of 11 children. We defined the glaucoma as elevated intraocular pressure of more than 21 millimeter of mercury with a cup disc ratio of more than 0.6 with specific changes in NRR as such as thinning or notching with or without RNFL defect or a disc asymmetry of more than zero point 0.3. And the treatment success was defined as reduction of intraocular pressure of less than 21 millimeter of mercury with or without AGMs. We recorded these parameters like demographic details, tonometry, gonioscopy and fundus examination, visual acuity and slit lamp, and of course the various management techniques. The age at presentation to our clinic was around, the median age was around 4 years, and there was a male preponderance with 63.6% being males. 2 of our 11 patients had a positive family history. Varied ocular presentations were noted in our group of patients, and 50% of the aniridic eyes had moderate to severe visual impairment. When it comes to the management, 11 of our aniridic eyes with glaucoma, 7 had a good treatment, successful treatment with 5 medical therapy alone, 1 with trabeculectomy and 1 with an Ahmed glaucoma valve implantation. Unfortunately, 4 had refractory glaucoma. When we plotted in Kaplan-Meier survival of aniridic glaucoma eyes treated medically or surgically, there was fall in intraocular pressure control to 80% in 1 to 1.5 years of treatment initiation. As you all know, the prevalence being very rare, which is around 1 is to 47,000 to 1 lakh, aniridia is a rare clinical disorder which features a lot of various ocular associations, which can be keratopathy, cataract, and of course glaucoma. Our median age was around 4 to 7 years, which was almost close to a review by Netland et al., which when in his study where he had noted around 8.5 years. 85% of the patients had moderate to severe visual impairment or blindness with BCVA of 20 by 100 or worse. This was similar to studies done by various authors like Angma et al., Shenlak et al., and Leet et al. The reported incidence of glaucoma is around 6 to 75%. In our study, glaucoma occurred in 50% of the aniridic eyes. 17 of the 22 eyes were treated with AGMs, including 3 eyes which were already on AGMs at presentation, of which the optimal IOP control was achieved in 4 eyes with medical therapy alone. Most of the eyes, 10 of the 17 eyes, required 2 to 4 AGMs, while 7 of 17 eyes required less than 2 AGMs. As I mentioned, the 7 eyes achieved. So the post-trabeculectomy bleb, we had 1 successful and 1 failed trabeculectomy and 1 failed AGV. So 59% of our aniridic eyes used visual rehabilitative measures, which included monoocular telescopes and dome magnifiers. Conclusion being, management of glaucoma is an enigmatic challenge, but it is important to visually rehabilitate these children also so that we give an holistic healthcare treatment. Thank you.
Any role of CCT in measuring IOP in such cases?
The challenge was some of these patients only we could examine in the OPD. So the CCT measurement we have taken it, but most of the time they have slightly thicker corneas in aniridic children.
So that's what in such cases you have to.
Yeah.
And the role of goniotomy in early cases?
Personally, I have not tried goniotomy in any of these patients. Not very sure because most of the time there is an anterior insertion of the iris. So then goniotomy may be challenging in these kind of eyes.
You said that you performed RNFL analysis in these cases, in all cases?
No, sir. No, only whichever patients we could check in the OPD, not the very young children, The ones which are like above 8, 7, 8 who were cooperative in the OPD only we could perform.
You think
Otherwise, we couldn't
you think
perform the
that
babies.
OCT data is
Not
compatible with this kind of age group?
not really, sir.
So
OCT analysis only clinically if you are seeing any kind of an RNFL defect more than the OCT changes.
This is a retrospective analysis, no?
Yes,
How
sir.
long have you kept these people in follow-up now? How many years now?
Average of almost 6
6 years,
years.
and they're
Yes.
doing well, most
Yeah.
of them.
Yeah. Like few are refractory. We
4
have
were
done a
refractory,
CPC.
but
Yes.
otherwise the others are done well.
Yeah.
Vision improved.
Vision wise, whatever maintained, they could get, they have maintained, and we have done a visual rehabilitation, which they'll be using. Some of them are using dome magnifiers and telescopes. 50% had a visual impairment.
Okay, thank you.
Thank you.